So guess what? I'm 10 days out from having my knee resurfaced, a total knee replacement. And normally when we're talking or helping people wrap their heads around post-surgical management, where usually there's kind of three goals. Hey, do you have some neuromuscular control of those tissues? Can we control your pain? Can you control your swelling, right? So one of the things that came up for me is that, man, normally I guess it's been a minute since I've been so close to someone with a total knee arthroplasty. And typically I see most sort of shoulder trauma, shoulder repairs, I see ACL repairs. Of course, I've worked with a ton of knee arthroplasty, not in that first 2-week acute phase. And one of the things that happened for me is I realized my initial goal was to try to be ahead of swelling within 24 hours. And you can see 10 days later, I actually have very little or no bruising in the system as a side effect of trying to pump out and be really aggressive about managing the sewage or the lymphatic system, which is the way I'm dumping all of this swelling. But certainly what I felt or have come to feel is that, man, I had to be on it. And I mean using my H-wave obsessively, in the Normatec boots at least a couple hours a day, getting on my back and really putting the legs straight up to elevate, and even voodoo wrapping compression for 1 or 2 minutes, high level compression with my foot up, right? But one of the things that kind of came into the conversation was someone said, hey, would you have done this surgery if you didn't have access to these tools? And what I really want to talk about is sort of this mismatch currently between where we're seeing people post-surgically and what that means to their sort of system. Less movement, more fearful movement, lots and lots of swelling. More importantly, very, very few ways to manage that swelling. Now look, we know that pain and post-surgical swelling sort of are interactions, right? That the surgical insult is going to drive an inflammatory response, but an unchecked inflammatory response where that fluid is just in the tissues and the tissues are extended really can drive a lot of discomfort and pain. And if you only ever hand an athlete or a patient or a person one mechanism by which to manage that pain, which is an opiate, or it's a narcotic, then we can see how we end up with less than effective the sort of healing phases and potentially a real mismatch between sort of getting back on your feet and getting off opiates. And what I want to say is that my surgeon uses a suture. He likes to suture and not tape and close and give that joint a chance to express the blood out of it and weep a little bit. Totally fine, love that model. But in the hospital, I was sent home with a wound vac, which was just a little vacuum, and it basically, with a sponge on the knee, and it basically vacuums those sides closed and then takes away some of the blood that was expressing from the wound, from the incision. And one of the things that I had a conversation with this young physician was, hey, look, I have a plan to actually stay ahead of this swelling. I suspect this thing will be bone dry in 2 days. What's the plan? He's like, no, keep it on for 2 weeks. And really, in that language or in that discussion with this physician was sort of tacit acknowledgement that we don't know how to manage your swelling currently. You're going to be very, very swollen and leaking from your wound for upwards of 10 to 14 days. And I was like, that's not the case. I'm going to be ahead of this thing. And, what we're seeing is, man, if the idea is to wait around and then further just sort of re-inflame the tissues through icing, right? That icing makes those lymphatics a little bit more porous. They come back in, you reinvest that tissue, which is already, all the fluids which have already been sort of segregated back into the system. You get into this horrible, horrible swelling phase. And what ends up happening is less desire to move, more muscular inhibition through the quadriceps for me. I don't want to stand, don't want to walk, and very few ways to manage pain. So one of the things that we need to make sure, and as I'm answering this question about how would I manage this, is making sure that people have a plan to be able to have some agency around managing their pain. So, one of the things that comes up is, boy, you sleep poorly at night sometimes because you have pain. And guess what? If we're appropriately thinking about that pain as information level, then we should be thinking, hey, I am going to not freak out that I'm awake, but realizing that my body's trying to nudge me to move a little bit, right? It's nudging me to change position. It's nudging me to be active. And that's a really, really powerful idea. And if I suppress that and just sleep all the way through the night, potentially I wake up and I have a more swollen joint the next day, right? And certainly feels like you can get behind, ahead, or behind. So what I want to appreciate here is that as we're thinking about post-surgical trauma, we can reach into the tool bag of the performance side of human beings and reach back and say, well, what are the ways that we are managing this adaptation response? And swelling is just an adaptation response to the surgical trauma. And giving people on-demand pain relief with high-frequency sort of energy through the joint meant that I could always have 45 minutes plus where I could take my pain down to almost zero. By jumping in Normatec, I could be managing swelling along with just the normal pumping through the low frequency, right? Elevate, voodoo. So what do we have if I don't have access to these? Well, I have elevation, voodoo. But what we need to do is psychologically get into a place where we're asking people, if you're having a really expensive surgery, why aren't we looking at helping people to manage these fluid loads? And again, in these big sort of buckets of things I'm trying to get done or manage up front, post-surgical swelling can drive a lot of discomfort, a lot of poor outcomes, a lot of unmanaged pain, and a lot of trauma in people's lives trying to get back or try to heal from this thing and continue to occupy their role in society. So would I have had this surgery without these things? Whew, it would be a different conversation, but I would absolutely be on the voodoo compression at the very least, right? Wrap, 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 but I'd have to wrap 20 times a day. I'd have to be thinking about elevating massively. And then, it's useful in this conversation is to appreciate that we are systems. We are a system of systems, as we've been saying forever. And that, man, I have to be looking at this lymphatic drainage system as my primary concern and goal. So, from our friends, Perry Nicholson, Stop Chasing Pain, putting a warm compress on the groin. Remember, all of these lymphatics are drained through the groin and ultimately through the trunk. And so if I can change the viscosity of that fluid, if I can change how well it moves, right, and get it out by improving the warmth and then getting some much other movement or some rubbing or compression or movement without motion, then that can be a big difference. Addressing organ function and breathing can make a big difference. We'll make a video about a couple other ideas, but teaching people how to basically decongest their trunks with like breathing techniques like dragon breath, fire breath, all of that stuff. Those are all pumping mechanisms. And so when we realize there are a lot of tools we can take from our performance side and apply them right over into that medical side, we may not be doing or at the leading edge of what's possible for human healing. So again, bottom line, man, you have to have a plan going in. And if you know someone who's having surgery or you're having surgery, really, really important that you're thinking in these terms, because what happens in the first week sets you up for the second week, sets you up for the fifth week, sets you up for the, and it's easy to do is be far behind. And how can we possibly be putting the kinds of sensory motor input back into the system to get the system back connected to my brain if I'm overridden by pain and poor desire to move? So, bottom line, you gotta have a plan. Work the plan. Or as I like to say, pump the knee, Johnny.